So Marcel, you can begin recording. And just request that everyone put their view on gallery so we can all see each other, and turn on your cameras so we can see each other. So my name is Rhea Markowitz. Oh, I see that Dr. Patton is coming in right now. That's good. So I'm Rhea Markowitz, and I'm from the Georgia Cancer Center, and I'm part of the hub team of our TeleDerm project. And Doug Patton, Dr. Doug Patton and I will be co-facilitating this session as usual. So I welcome and introduce our teledermatology primary care providers today. So if you can wave as I mention your name, we've got that Dr. Sam Walling from Lee Medical Arts. And we've got Lori Hutchins from EGHC Mount Vernon. There's Lori. Maisha McFarland from Soperton. There's Maisha. Stephanie Cawthorn and Carolyn Jones from Baxley. There's Carolyn and Stephanie. No, okay. And Floyd Soriano. Did I see his name or not? Okay. Or Phyllis Solomon from Metter. But so Billy Stout from Sylvania. Billy, are you waving?
Yeah.
Oh, okay. All right, there you are. And Sean Ferrier from Wadley. Okay, so glad to have you all on board. So I also want to welcome our residents and maybe some students from AU's Department of Family Medicine in their large conference room there. And family medicine folks, will you send me a list of all of those of you who are attending? And then I don't think Dr. Cortez is here today. But I want to dermatologist, Dr. Davis, Rabinovitz, and we have derm residents. Is that Sue here? Well, okay. And I think we've got a couple dermatology, some medical students. Oh, so Gaby is a medical student, and nice to have you here. And Hannah, did we lose? Oh, there's Hannah up there. And Hannah will be presenting today, and I'm not sure if there are any others. And then, of course, the members of our TeleDerm team. So we have Enza Mamuni and Marisol Miranda here in the hub at the controls. We have Brenda Santiano, who by the next session, she will be at the controls. We're still waiting, taken care of, so she can be on board as a regular part of our team. And then we have Mackenzie Maloney, another medical student here in our hub room. So welcome aboard, everyone. So as usual, we would like you to put into the chat your name and your clinic, where you're from, or not just your clinic, but who you are, medical and resident, whatever, into the chat. And I think there should be a listing somewhere there, up there for you to follow. And we'll go to today's agenda. And so we will start as usual with our introduction, and then we'll go into the didactic session for 20 minutes with Dr. Buchanan. and she'll be talking about the many faces of Nevi Part 2. And then Dr. Sam Walling will do our first case presentation, and followed by our medical student, our senior medical students for the second case presentation, and then we'll have the wrap up and announcements. So now I will turn it over to Dr. Doug Patton, who will take over today's session. So Dr. Patton is, I've said many times, is the Dean of the Southwest Georgia Regional Campus for Medical College of Georgia, and has spent most of his career as a rural physician. So Doug, take it away.
Thank you, Rhea. It's good to be back with everyone again, and thanks everyone for joining. I'm sorry I was running a little tight on time there, but we're going to get started like we usually do by reminding ourselves about Project ECHO, and sort of the tagline being moving knowledge instead of people. ECHO obviously standing for Extension for Community Healthcare Outcomes. Next slide, please. So these sessions are designed to improve our knowledge, and in this case around telemedicine, specifically teledermoscopy and teledermatology, to help you at the local level to improve your skills and to enhance the services that you can provide for your patients right where they are, so that they don't necessarily have to travel long distances just to get an opinion. This helps, we believe, to overcome some of the disparities faced by the people that you all serve on a daily basis. Next slide. So again, this is for educational quality improvement purposes. They're recorded, and you're consenting to being recorded by being here with us at this point. And a reminder to not mention any PHI during the presentations or discussions. There will be information in the chat relative to continuing education. And of course, you can always email other questions if outside of the chat to teledermatology@augusta.edu. Next slide, please. So we gather information about this project from registration all the way through completion, including surveys, and the sessions are recorded. So everything in the chat as well. And we use this information to help us not only report back to the Project ECHO folks in New Mexico for their purposes, but also to help us improve the quality of what we're providing for you. We're open to feedback all the time, and depend on it actually to make sure that this is a valuable use of your time. Next slide, please. So just in general, remember to mute yourself when you're not speaking and unmute when you do speak. You'd think 2 years into this, we would all have that figured out right now, but I have to be reminded every now and then to unmute. You can type questions into the chat at any point along the way. We'll be monitoring the chat and make sure that we can kind of combine questions if we need to, and try and address them all as best we can. If you need to speak, once we get done with the presentation, you can raise your electronic hand by hovering over the reactions button. You'll see the raise hand button. Once you're called upon, you can unmute yourself, introduce yourself, and make sure your cameras stay on as much as possible throughout the entire hour. It's important for us to be able to see folks. That way we can monitor a level of engagement. So it helps us a lot. Again, technical problems, another opportunity to email is kmamouni@augusta.edu. Next slide, please.
Good afternoon, everyone. So these are two cases that I sent for the
Let's see, we've got a case presentation put up here, but I think
We're supposed, unsure.
let's see. I think we're supposed to go next to Dr. Buchanan. So it's my pleasure to reintroduce Dr. Kendall Buchanan as our featured speaker today. She's in the Department of Dermatology here at AU, and she practices in the AU Care Center over in Aiken, South Carolina. This is the second part of her talk, Many Faces of Nevi. And this will be, again, about 20 minutes. We'll try and have some time left over at the end for questions, either those that are in the chat or those that are live. So, Dr. Buchanan, you've got it now. Take it away. Thank you.
Awesome. Thank you guys for having me again today. I'll go ahead and start. We'll dive right in. So this will be the Many Faces of Nevi Part 2. So today we're going to talk about what influences Nevis patterns, and then we're going to review special types of Nevi. So I think today, for the most part, we're going to talk about, the things that we've learned before, but in kind of a different context. So towards the later half of the presentation, you might think this is a lot more challenging, but just kind of bear with me, and we'll get through it. And I promise you will learn a lot. So these are just the patterns that we reviewed last month. We won't go into too much detail today. So today we're going to talk about, so why are we learning about this? Why is this important? And one of the main reasons is because we want to identify and excise all lesions that could be potentially melanoma. And along those same lines, this allows us to reduce the number of biopsies and excisions of benign nevi. So when we think about this, again, we think about this in terms of pattern analysis. So what is normal? What is abnormal? And today specifically, we're going to talk about what influences Nevis patterns. So these are what I like to call the big three. So skin type, age, and location. So we're going to dive right into skin phenotype. And first, we're just going to briefly talk about what is the Fitzpatrick scale. I kind of mentioned this last month, but essentially the Fitzpatrick scale was developed in the 1970s by Dr. Fitzpatrick. And this was created to predict the appropriate dose of UVA for psoriasis treatment. And it was based on questions that patients were asked about, how they burn and if they are able to tan at all. And so as you can see here, it's divided into types 1 through 6, with type 1 being someone like myself who's very fair skin and I burn very easily. And then type 6 would be a patient who has dark skin and tans very easily. Okay. And so, when we talk about skin phenotype and when we talk about moles, we know that skin phenotype influences patterns of Nevis. So Dr. Zaludek has done several studies in regards to different Nevis types in patients. And as you can see from this chart here, a lighter skin individual will typically have lighter nevi. And this sort of progresses as the skin phenotype increases. So darker nevi are going to be more commonly seen in someone with a darker skin pigmentation or a higher skin phenotype. And so it's important to keep this in mind when you're evaluating moles, because it can kind of help you determine if a mole is potentially benign or more likely to be malignant. And this is just another example here of a typical peripheral reticular pattern with central hypopigmentation seen in a Fitzpatrick 1 patient, and then sort of the opposite of that, a peripheral reticular pattern with central hyperpigmentation that's seen in a Fitzpatrick type 6 individual. And this is just another way to kind of show that. So as the skin phenotype increases, the central hyperpigmentation in nevi increases and the central hypopigmentation decreases. Similarly, you have as skin type increases, the darkness of moles increases in the same skin type. And so these are just things to kind of keep in mind when you have patients that you're evaluating. And this kind of brings me to talk about the ugly duckling sign. So basically, this is something that we can recognize because it's a Nevis that's different from the others in the same patient. And this has been studied, and it is a major indicator for suspicion of melanoma, both dermoscopically and visually. Another reason that this is specifically helpful is because what we know is that Nevis diversity is fairly limited in every individual. Typically, we see 1 to 2 patterns of nevi in any given individual. And so this is sort of like your individual reference system, which we can intuitively perceive. So in regards to age, there have also been several studies of Nevis patterns in this context. And so for adults, for example, it's more common to see this reticular pattern, where we talked about last week, the central blotch with sort of the surrounding delicate network. And in children, it's more common to see a globular pattern. And usually we can think about that because in children, we have a lot of growing moles. So globules in nevi tend to be associated with growth. And here's just another example from Dr. Zaludek. And as you can see here, this sort of persistent globular pattern is commonly seen in children. So in this example, less than 14. As you go through adolescence, you can start to see this peripheral rim of globules, which, as I mentioned, indicates growth. And then you start to kind of lose that dynamic pattern as you go on into adulthood. Now, it doesn't mean that you can't see, globular patterns in adulthood, but typically it's going to be uncommon to see a dynamic change, such as peripheral globules or more than one tier of globules. Now, when we talk about location, I think this is particularly fascinating, but so we can think about this in terms of the different patterns of nevi that we have. So Dr. Scope and I believe it was Dr. Margouf have studied nevus patterns in children. And particularly they found some very interesting patterns in that globular nevi were typically more commonly seen on the upper compared to the lower back and also the head and neck. They also found that these patterns are fairly uncommon on the lower legs. They also looked and found that globular and homogeneous patterns were increased in frequency in lighter skin types. Now, contrast that to the reticular pattern. So reticular nevi are common on the back and the extremities, and they're often evenly distributed on the back. So same distribution upper and lower. And then they also found that reticular nevi were the more dominant pattern in darker skin types. Now, that doesn't mean you can't see globular patterns in darker skin types. These are just sort of generalizations, but again, can help you when you're evaluating nevus patterns in patients. There's other things that we didn't have time to talk about today, but there's different algorithms for nevi of special site. For example, facial nevi, nevi on the palms and soles, and mucosal nevi. And so hopefully we'll get a chance to dive into some of these later this year. There's other things to keep in mind when you're evaluating nevus patterns. So pregnancy, UV exposure, and if they've had a history of melanoma. Moles can change somewhat in pregnancy. You just kind of have to use your clinical judgment along with the history. UV exposure, this is particularly interesting. We know that moles can darken with UV exposure, so important to keep that in mind, and history of melanoma. So now that we've kind of talked about, those different patterns and what influences the patterns, today we're also going to talk about some special types of nevi. So these can be a little bit challenging. So I tried to provide a little bit of clinical background to kind of help you, because sometimes you can go down a rabbit hole if you're just using your dermatoscope alone. So the first one we'll talk about is intradermal nevus. So intradermal nevi, there's different types, but clinically they can be raised or dome shaped. They can be sessile or mammalated, and these can lose pigment over time. So if you start looking at your patients, you'll start to notice intradermal nevi. They're fairly common. They may have hairs. And so on pathology, what we see is melanocytes that are primarily confined to the dermis. These often arise before puberty and may become raised over time. So usually your patient will say, oh, Dr. Buchanan, I've had this forever. So that's kind of a good idea. You can't always go by that because sometimes intradermal nevi will mimic basal cell carcinoma. There's two different types, Una nevi and Meissner nevi. So Meissner nevi are commonly found on the face, and Una nevi are commonly found on the trunk and extremities, and they can have different dermoscopic patterns. So these are just some examples of Una nevi and Meissner nevi. Usually the Meissner nevi tend to be more dome-shaped, and like I said, these are more common on the face. And Una nevi, may have more of like a skin tag-like appearance and more common on the trunk. So I bring this up So this is what's called the wobble sign. I didn't have a great way to show this, but if you put your dermatoscope on the intradermal nevus and kind of move it back and forth, it will often appear to wobble. And the best example I could find was kind of like Jello. So that's just something to keep in mind as you're evaluating intradermal nevi. So they can have different dermoscopic features. So globules are globular-like structures that form a cobblestone pattern. You can see pale to whitish structureless areas, different types of vasculature, which we'll talk about, and then focal brown structureless areas, focal network, and some exophytic papillary structures. So this was a study done by Dr. Greco and colleagues, and so they studied the different vascular patterns with intradermal nevi. So what they found was that the most common pattern was polymorphous vessels, which means more than one pattern. Out of that, they found that the comma type vessel and arborizing type vessels were the most common. Out of the monomorphous vessels, so one pattern of vessels, they found that comma vessels alone were the most common. And we'll go over a couple examples of those. They also noted this interesting Y vessel. The reason this is important is because when we talk about arborizing or branching vessels, we usually use that in context of a basal cell carcinoma. So in this case, you'll see that there's only one branch which forms this Y appearance, which is, what we can see with intradermal nevi. These again are just different types of vessels. So comma vessels kind of look like a small curvy linear vessel. And then the other ones are pretty self-explanatory. Interestingly, they did not see glomerular crown hairpin and arborizing vessels alone. Okay, and that was an interesting finding in this study. And here are just some examples here. You might look at this and think, wow, this looks disorganized, but I think you have to understand what you're looking at. If you have a clinical suspicion for an intradermal nevi, you can look at this with your dermatoscope and confirm. Okay, so you're going to see those comma-like vessels or fine linear vessels, some pale white structureless areas, and then globular-like structures. This is another example. Take note of the hair. So this has that kind of mammillated appearance, focal brown structureless areas, and you can see fine vessels that can sometimes be out of focus and also see a white halo. And here's another example, courtesy of Dr. Rabinovich, where we see those multiple comma-like vessels. And so this is just a comparison of a basal cell versus an intradermal nevus. As you can see with basal cell, you have very sharp vessels. They pop out with your dermatoscope. Intradermal nevi often have more dull vessels that are commonly out of focus, and they have sort of a different background hue. So the next up is a Spitz nevus. These were previously termed melanomas of childhood, mainly because they can clinically look very concerning. However, Spitz can be different types. You can have a pigmented and a non-pigmented Spitz. So it's important to keep that in mind. The head and neck is a very common location, as well as extremities. And usually these are going to be seen more commonly in younger patients. So a diagnosis of the Spitz nevus in an older individual is going to be rare. And you always need to keep in mind that these can sometimes mimic melanomas. So you have different types and different dermoscopy findings based on if the Spitz is a pigmented or non-pigmented Spitz. And we'll go over these different types. Takeaway from this slide is that non-pigmented Spitz nevi are going to present predominantly as a vascular pattern. So this is going to be a pink papule with often vessels as dots. So here are just some examples here. Pigmented Spitz, this is the more common pattern that we associate with Spitz, called the starburst pattern. So you see these radial streaks, as well as this homogeneous black-brown area. And then, as I mentioned, this is a classic example of the vessels as dots pattern for a non-pigmented Spitz. Here are just some more examples. They have lots of different dermoscopic features that we will continue to look at. So this is a globular pattern that's diffuse, and also a homogeneous pattern. So, the takeaway from Spitz is that these can be extremely complicated lesions. I think that you have to have a high clinical suspicion. It has to, if it's a younger patient, this can provide reassurance, as well as some of the more common patterns, starburst patterns, globular patterns. These are probably the more easy to recognize. Keep in mind that Spitz nevi are uncommon in the aging population, and if something is clinically and dermoscopically concerning, it probably will need to be confirmed with a biopsy. Combined melanocytic nevi, equally as challenging. I saw a patient today and I was, always tempted to biopsy because these can be really hard. Usually these are a combination of a blue nevus and a congenital nevus. So you will see both those features under pathology. And usually this is not a new lesion. From what we know on dermoscopy about these types of patterns, these can be really, really hard to tease out, and even more so hard if there's not a blue nevus in association. So most commonly, you will see a common blue nevus in association with a dermal nevus, as you can see here. And so when you're evaluating combined nevi, you will often have your melanocytic component, which is your network and globules, as well as some vasculature, and then you have your blue nevus component. And so these are just some examples here. Again, these are challenging, even for someone such as myself, Dr. Rabinovitz, like we all take a second look at these and, scratch our heads because you're seeing multiple different patterns and it may look disorganized. So you kind of have to have a good clinical suspicion. And here are just some examples of a Spitz nevus with a Clark's nevus, and then a blue nevus with intradermal nevus. Equally challenging, I know I'm making this hard today, guys, but recurrent nevi. So recurrent nevi are, they basically arise from residual melanocytes that have remained within the sweat glands and hair follicles after a biopsy is done. One sort of tidbit is that recurrent nevi often have their pigmentation confined to the scar, and this has been studied. So you really want to take into context, do you have the previous histopathology report available? Is the pigment located outside of the scar? Because your main differential is going to be a recurrent melanoma. And so recurrent nevi versus recurrent melanoma, this has been studied. And so what we know is that recurrent nevi are more common in individuals younger than 30, and the time period to recurrence is on average 8 months. Contrast that with a melanoma, you're more likely to see a recurrent melanoma in a patient older than 30, and the time to recurrence is going to be on average 26 months. These are other features that we see. Recurrent nevi tend to be on the torso compared to the head and neck with a melanoma. The growth pattern with recurrent nevi tends to be centrifugal. Compared that to a melanoma, it tends to be more chaotic. And so these are some features that Dr. Bloom noticed whenever he was evaluating dermoscopic patterns. So recurrent nevi have radial line symmetry and a centrifugal growth pattern. I used to be an engineer, so I had to put this in here about centrifugal force because I think it really helps to show kind of how the pigment is just drawn out. Contrast that to a melanoma, you have more of a chaotic or non-continuous growth pattern. And pigmentation beyond the scar's edge, which is very important. So here are some examples courtesy of Dr. Rabinovitz. You can see that the pigment is confined to the scar, looks very symmetric, has radial lines. Here are some other examples from Dr. Bloom's paper. These are a little bit more challenging, but I just show them here for completion. And then compare this to a recurrent melanoma. So they noted that you can see circles, which are more commonly seen on the face. And all of these examples have eccentric hyperpigmentation. You see more of a chaotic growth pattern, okay? So halo nevi, these nevi are seen more commonly in children and young adults. So this is basically a nevus that's surrounded by hypopigmentation or a light ring. Most common on the back, and these children may have multiple. The age of onset is usually around age 15, and they often have a family history of similar nevi. They may also be predisposed to atopic dermatitis or potentially autoimmune history. So the halo phenomenon, while uncommon, should be viewed cautiously if other melanoma-specific features are present, especially if in an older individual. So this is just kind of a background slide from Dr. Combe, which shows that they're more common on the back. And you can see some of these patients in his study had, history of melanoma or history of autoimmune disease. The two most common patterns that we'll see with halo nevi are the homogeneous pattern and the homogeneous globular pattern. So this is an example of the homogeneous globular pattern. You see a central globular area with surrounding peripheral white halo. And then this is a homogeneous pattern where you see a pink area surrounded by that white halo. Okay, and here's another example of the homogeneous globular pattern, homogeneous central area with globules and white halo. Similarly, you have just a regular homogeneous pattern with peripheral halo and the homogeneous structuralist area. Okay, this is a good picture of a halo melanoma. So as you can see, this is asymmetric. The halo is asymmetric. It also has multiple colors. It's a raised lesion. And in this particular case, there was notable recent enlargement. And this is a nice example. So what we know is that a percentage of halo nevi will completely resolve. So this was a retrospective study that was done in 2012 that showed about 22% of halo nevi completely resolved. The average time is a little variable. As you can see in this example, it took 3 years, so you can kind of follow along. So 2002, this lesion was on the trunk of a young female. And then as you can see, it kind of lightened over time. And then by age 19, you do not see any evidence of the nevi that was still there. So the average time is variable. I would say 3 years is a pretty short duration. Usually we say that they could persist for potentially a decade or longer. And then we talk about nevus patterns that simulate melanoma, and we've actually already talked about a couple of these, right? So combined melanocytic nevi and atypical cyst nevi. And so I just wanted to give a couple of examples of recent cases that I had that kind of highlight these features. So this is a 60, yes.
Shannon, we're at running time.
Okay, that's fine. I just had like 2 more slides, but we can stop.
You can do 2 more slides.
Okay, so this is just an example of a traumatized nevus. And the reason I thought this was an interesting case is because it had polymorphous vessels. So it made me concerned that it could potentially be a melanoma. So, in here, we talked about sort of the vessel patterns that are seen with intradermal nevi. And I did note the Y vessel, which, I did do a biopsy and it came back as an irritated intradermal nevus. And then this is just another case that came back as a high-grade dysplastic nevus. I was concerned because of the irregular brown pigmentation, atypical pigment network that was asymmetric. And so I did biopsy this and it was a high-grade dysplastic nevus. So I'm still going to bring this patient back and do a complete excision with 5mm margins. Okay. And so that was all for today. Sorry, it was a little bit rushed, but I hope we provided some good information. And the next time I talk to you guys, we will see, or we will talk about benign and fine, some characteristic features of common benign neoplasms.
That's great, Dr. Buchanan. Thank you so much. It is an awful lot of material. We don't want to rob time from the presentations, but if somebody had one question, I haven't seen anything in the chat. But if somebody's got one question they want to ask, if you'll raise your hand and we'll see if anybody's got one. Surely one of the students or one of the residents has got something out there that's they're just dying to know. Okay, well, we won't belabor that. I have one that I'm going to hold in case we have time on the back end. But at this point, it's my pleasure now to introduce the presenters for the cases today. And the first presenter will be Dr. Sam Whaling, who's one of our clinic providers. And Sam's getting to be, I won't say he's an expert yet, but he's getting close to being an expert on how to deal with this and how to present and everything else like that. Dr. Whaling, you got a few minutes for us to hear a case from you, and then hopefully we'll have some questions after that. Thanks for joining us again.
You need to unmute.
Can you hear me now?
We can.
And can you see my shared screen?
Yes, we can.
Great. Well, like Dr. Patton said, I am Sam Whaling. I am a family physician down in Leesburg, Georgia, Southwest Georgia, at Lee Medical Arts. I have the privilege to have some Medical College of Georgia students with me during the week. But I do want to thank Dr. Benovitz and Dr. Buchanan for helping me with this presentation. So my patient is a 68-year-old woman who came in with a scaly red papule on her right ear. This was her concern, her chief complaint for the visit. And it was a lesion that had been present for more than 3 months. It hadn't particularly changed in color, size, or shape. There was a scale and a history of bleeding. And there was no personal or family history of cancer. And just when I submitted my case, the recommendation, the diagnosis was potentially most likely squamous cell carcinoma, and a biopsy was recommended. So here's a dermoscopic picture. And as we can see, there's erosion. There's vessels with red dots in the periphery out on the right side of the picture. There's a fine scale, and my next picture will show these potential coiled vessels. This is a little bit more of a close-up, also called glomerular vessels. So in our approach to evaluate the lesion, we use our two-step diagnostic algorithm. We try to determine whether it is melanocytic or non-melanocytic. And so we ask that question, and we ask that question by seeing if it meets the classifications of a melanocytic lesion, which would include if it has a network, if it has globules, streaks, or a homogeneous blue. And there are non-melanocytic lesions like dermatofibromas and solar lentigines that do have a network, but in this case, the pattern trumps the structure, so it's non-melanocytic. So we answer that question: is this lesion a melanocytic lesion? And we say no, it is not. It does not have any of those characteristics. To further round out what the potential non-melanocytic lesions would potentially be, dermatofibroma, basal cell carcinoma, seborrheic keratosis, solar lentigo, lichen planus, hemangioma, or some vascular structure, and squamous cell carcinoma. And so at this point, when we determine if it is non-melanocytic, we search for any vascular structures or patterns. So one of the structures or patterns that we saw were the vessels as red dots, or those glomerular vessels. And so that can kind of help us focus in. So the vessels as dots themselves have a differential of the non-melanocytic lesions, which include squamous cell carcinoma, the porokeratosis, psoriasis, clear cell acanthoma, and dermatofibroma. So some dermoscopic features associated with squamous cell carcinoma, we were to think that this would potentially be it and that we could correlate, would be the glomerular coiled vessels, which we saw in our picture, but you might also see white circles, brown circles, rosettes, bright or brown dots with radial arrangement, yellow scale, strawberry pattern, or hairpin vessels with a whitish halo. So if we're potentially thinking that this is a squamous cell carcinoma, then we have to consider what our management should be. So, like I said, when I submitted my image, Dr. Rabinovitz recommended a biopsy. I sent this patient out to a local dermatologist, and they determined that it would be appropriate to do cryotherapy. So that was performed, and my goal was to bring my patient back and take a picture so that we could discuss and see after cryotherapy if it was adequately treated or not. Unfortunately, I got COVID, so I was not able to bring the patient back. And so now, kind of just going off of our picture and the story, I wanted to have a discussion that I couldn't do any justice for leading in determining whether a biopsy or a cryotherapy should have been the management of choice. And so it may be a gray area, but I did want to see if some experts would want to chime in and give their expertise or their expert opinion on this matter.
Thank you, Dr. Whaley. Who wants to chime in? Dr. Rabinovitz, Dr.
So basically, based on the dermoscopy features, the features are most characteristic of a squamous cell carcinoma in situ. So for squamous cell carcinoma in situ, I would normally do a shave biopsy. And for a small lesion like this, if it's positive, it's a small area. This could be treated by curettage and desiccation. That being said, cryosurgery has been used for Bowen's disease. So for this particular patient, if it was frozen by the dermatologist and he gets the appropriate response, that's an alternative way to treat it. But I certainly would bring the patient back to see that the area has completely resolved.
Dr. Davis, you have anything to add to that?
Yes, I would agree that this patient needs close clinical follow-up. I think I'm impressed with the fact that the lesion is so eroded. And so many times I try to stay away from freezing lesions that are totally eroded. That means, most of the epidermis is gone there. So personally make me a little nervous doing that, but I don't think that's inappropriate. But I would want to take a look at this just to make sure the margins are definitely clear, because the margins are a little hazy here. And so you want to make sure if you chose to freeze it, you'd want to make sure that you got the entirety of the lesion. So yeah, I think these are things that are debatable. They're the way you practice, but you don't want this patient to not come back.
Somebody want to give us like a 30-second reminder about the differences between basal cell and squamous cell in terms of risk of local recurrence and risk of distant spread, just so that we got that in our mind while we're having that conversation about local treatment?
So basal cells rarely metastasize. And they always come back locally, especially if they're small. I mean, squamous cells have the potential to metastasize, not something of this probably size and depth. This doesn't look like it has any substance to it. So I think that that's probably very low risk. We have a lot of patients who don't want to be cut on. And so if this person said, I really want to, a lot of our patients have been frozen before. So they really beg to be frozen instead of biopsied when they come in. And so, if they want to be frozen, you say, that's okay. I mean, that's maybe not what I recommend this visit, but let's see you back in, 3 months, 12 weeks, and let's just make sure it's gone. And then follow up if they don't show up. But
Thank you for that. I don't usually have much to contribute, but because in my general surgery practice, I was often left taking care of skin lesions like this. And I would lean towards the approach that Dr. Rabinovitz talked about, where you would kind of scrape it and cauterize it and scrape and that sort of thing till you get back to what feels like healthy tissue. I found that to give me a greater sense of comfort that I'd actually gotten all of the lesion itself. So I don't know if that's good news, good advice, or terrible advice.
Yeah, I think it's a lot is who you talk to. You know, most surgeons would say, oh, got to do Mohs surgery. It's on an ear. But then, you know, there's a lot to do with experience too. And this is a very small lesion.
Sure.
Yeah, for sure.
All right, very good. Well, then let's move on to our second case. It's time for me to introduce Hannah Nazir. She's a fourth-year medical student, and she's going to give us our second case presentation. Hannah, are you ready to share? That's great. We can see that. There you go.
All right, thank you for that introduction. Can everyone hear me and see my screen?
We can.
Yes.
Thank you.
Great. So my name is Hannah Nazir, as Dr. Patton mentioned. I'm a fourth-year medical student here, and I'm very excited to share this case that was seen in clinic with Dr. Buchanan. I'd also like to thank Dr. Buchanan and Dr. Rabinovitz for all their help with this case. So just to start off with our case, we have our patient. So she was a 67-year-old female coming in for her full body skin check. She did not have any prior history of skin cancers, though did report that she was in the sun a lot. And so on her right lower leg, she has this mole that was a little bit concerning. And so when you have, a pigmented lesion like this, there are certain clinical differentials to work through. It could be a melanocytic nevus, a seborrheic keratosis, perhaps a solar lentigo, and most concerning would be a melanoma. And so what we can do is look at this image under dermoscopy. And so this is what the lesion looked like. And in the next few slides, we'll run through a little bit of the features of this lesion. So the first step for evaluating this pigmented lesion would be to work through a two-step algorithm. The step one would be, is it melanocytic or non-melanocytic? And step two would be, if it is melanocytic, is it benign or malignant? So for step one, is it melanocytic or non-melanocytic? So looking at this image under dermoscopy here, we do see the presence of a pigment network. We see some fading at the periphery. Additionally, we do see the presence of these dots and globules here. So overall, yes, we would say it is melanocytic. For step two, is it benign or malignant? And so the first feature to sort of study here are the colors in this image. And so here I see tan and dark brown. So I see about two colors. Generally, if you see more than three colors, you're more concerned about something malignant. As for the symmetry, we look at the pattern and the shape. And so pattern is generally more important than shape. And so for the pattern, we can say that it does definitely appear to be asymmetric. If you look at all these dots and globules, they're sort of clustered on the left here. And so overall, it is an asymmetric pattern. And if you look at the shape overall, it is asymmetric as well. And so overall, for this image here, this lesion, we can say that it is disorganized. So the next thing to ask is, does this have any melanoma specific features? And so these are 11 features that I know were discussed previously in our TeleECHO sessions. And so the first feature to point out here is that it seems that this has peripheral tan structureless areas here. And so what's important to point out is that in general for melanomas, these peripheral tan structureless areas compose about 10% or at least 10% of the overall lesion. Here it's cutting a little bit close, but it's still worth pointing out in this picture. And additionally, as I mentioned earlier, we see these dots and globules. And so what makes these atypical dots and globules is that one, they are asymmetrically distributed. They're not distributed throughout the lesion, but they seem to be more focally sort of clustered here on the left. And additionally, if you look at each of these individual dots and globules, they seem to be of different sizes and shapes. And so overall, we would say that we have at least two melanoma specific features here. This is just a side-by-side between the image of our patient's lesion on the left, and here on the right is a typical benign nevus. You can see the dots and globules are uniform size and shape, and they're also more uniformly distributed. So to put it all together, we would say that this is a melanocytic lesion. We see the pigment network, we see these dots and globules, and we would consider this to be concerning for a malignant lesion. And so there is some color variation. We see this asymmetric pattern, And additionally, we see at least 2 melanoma-specific features. And so the next step for this would be to perform a biopsy. And so this case, there was a shave biopsy that was performed. And so with histologic examination, what we see here on the left is these large irregular nests with some bridging in the epidermis. Additionally, on the right, you can see these atypical melanocytes, and there's this underlying lymphocytic host response. Here you see lentiginous growth of these atypical melanocytes along the dermal epidermal junction. And you can see that these nuclei are very sort of dark and hyperchromatic. Here you see the Melan A immunohistochemical stain that shows, again, these atypical melanocytes, and they have this upward, pagetoid scatter. So overall, these histopathological findings are consistent with a melanoma in situ. There was no invasion that they saw. And specifically, we would call this a nested melanoma in situ, especially given the presence of those large irregular nests that we saw in the epidermis. So what are some really important takeaways from this case? So the first point is that when you see these peripherally or asymmetrically distributed globules, they're more common in melanocytic nevi in younger individuals. And I think this is a point that Dr. Buchanan brought up earlier as well. This is something that you would see with growing nevi. However, if you see these peripherally distributed globules, it's less common for older individuals. And so lesions with peripheral globules are more likely to be melanoma if they're located on the lower extremities and have the presence of a disorganized pattern or one of these melanoma-specific features. And so in this case, this patient's lesion under dermoscopy had these atypical dots and globules. So why did I choose this, or why did we choose this case? So for one, it really reinforces some of these dermoscopic features of malignant melanoma. For example, we see this asymmetric pattern, asymmetric shape, and additionally, these atypical dots and globules. Additionally, it really highlights the importance of considering the location of a lesion that has this globular pattern in an older patient. So it's important to be mindful of the fact that lesions with globular patterns in older individuals are more likely or raise greater suspicion for melanoma if they're located on the lower extremities. And finally, this does highlight a case of nested melanoma in the elderly. And so nested melanoma is essentially a histopathological variant of a superficial spreading melanoma. And so you should consider this differential of a nested melanoma when you see a flat pigmented lesion that shows an irregular globular pattern in an older individual. So just a couple of questions, to think about, what would be your next step for treating this melanoma, and when would you want this patient to return for their next full body skin check? And so for this patient, I believe she'll be treated with surgery, specifically with wide excision. Since this is a melanoma in situ, it's technically stage 0. And so the margins would be, either 0.5 centimeters to 1 centimeter. When would you want this patient to return? So this kind of depends. So this patient, again, had a melanoma in situ. She did not have any prior history of skin cancers. And so kind of what I've seen in the literature is that they recommend that she return anywhere from 6 to 12 months for 1 to 2 years, and then annually afterwards. These are my references. And thank you for your time. And I'd like to thank Dr. Buchanan and Dr. Rabinovitz for all of their help. Are there any questions or comments?
Thank you, Hannah. Let's see, I'm looking at the chat. I don't see any questions there. Someone from the audience. Do we have any questions?
Hannah, do you want to stop sharing?
Sure.
We take questions now for Hannah or for Dr. Whaling or for Dr. Buchanan. We got just a couple of minutes. A special thanks to all of you for presenting, but especially you, Dr. Whaling, for presenting from your state of COVID isolation. We appreciate you staying with us anyway. So that's good.
And I think it's wonderful for Hannah as a fourth-year medical student to be presenting.
Absolutely. Thank you, Hannah, for that. So any questions or comments? So I had one, since there doesn't seem to be anyone else that's got one ready, and this is a toss-up. I'll leave it for anyone. It's specifically about halo lesions. I want to make sure that I understood, Dr. Buchanan. Halo lesions sometimes resolve on their own and things like that. Does the fact that it's a halo lesion, a pigmented lesion with a halo around it, is that more favorable or less favorable or agnostic relative to risk? Does it make any difference at all?
So halo nevi are very, very common in children and young adults, and they're benign. We don't treat these. We would treat a lesion which dermoscopically and clinically had features suggestive of a melanoma with a halo, but those are extremely rare. You sometimes see a halo phenomenon in someone who has metastatic melanoma. And again, this is rare as well, where some individuals who are responding to some of the newer medications to treat metastatic melanoma. So halo nevus in itself really does not add any additional risk.
Perfect. Thank you. Appreciate the clarification on that. All right, with that, I'm going to turn it back over to Rhea to close us out.
Okay. These were two great presentations. So I'm happy to have had all of you attending today. Our next session is delayed a week because of Labor Day, so it will be September 12th. And I lost my slide. Dr. Buchanan will be presenting on benign and fine characteristic features of common benign neoplasms. And Dr. Jabo, one of our dermatology residents, will be presenting one of the case studies. And then Sally Young will, another medical student, will present the second case presentation. So thank you all for being here, and we will see you on the 12th, and enjoy this steamy month of August, and hope we receive lots of consults from our clinic people. So thank you. And those of you from the spokes and the rest of the guests can now sign off. People, the teledermatology people, stay on for a few more minutes. Thank you. Bye-bye.
Thanks, everyone.